With neural tube defects, specifically focusing on spina bifida. Y'all, the content is straight out of your PEDS book. If you haven't read it, I recommend it simply because it's only about like 6 pages. It starts on page 1116 and it ends on 1024. Everything that you need to know is in there. It's on this test. I mean, it's straightforward. This is a child that has a problem with their spinal cord, and we have to do the things to protect them. First of all, we have to start out with the mama, because this can be prevented with B vitamins. That's why when everybody's talking about, well, I'm thinking about getting pregnant, they always put you on folic acid, right? For the men, this is what they do. The men don't take folic acid because it don't help. But since they've started doing that, the incidence has gone down, but it's still present, and you will see children with spina bifida. Now, on your little worksheet that you have, it says what's the 3 types. Actually, it's 2 types with 2 subtypes. You have spina bifida occulta, and then spina bifida cystica, and the cystica has the 2 different types. You have a meningocele and a myelomeningocele, and you'll see the difference in just a minute. I really don't like this room because I got too much room to roam, but the level of injury, it's kind of like a spinal cord injury. The higher it is, the worse it is. The lower it is, the fewer problems that you have. And by knowing that, you know what to expect with your kids when they come out. Yeah, it's 2 pages. I'll get you another one. I'll tell you what. Who's missing this? Well, some of them were stapled. No, it's 1 pack of 2 sheets. If it's stapled, it's all together. That's all you need. I miscounted when I did this morning, so do you need another page? There you go. So now I don't even know what's on it. Trust me, I've seen it done. But you will have specific nursing responsibilities when you see these kids. Most of the parents know that they're going to have that neural tube defect by the testing that they do. And so they're kind of prepared for it. But who's really prepared to have a child that's going to be special needs? Who really knows what that's going to entail? So we're going to watch this video on spina bifida, and then there's another cool video coming up on how they're fixing them now. And you got to remember, you know, when they first started having these, well, I won't say when they first started having these issues, before we had the technology that we do, these children really had a hard time because a lot of them are paralyzed. They have deformities of the lower extremities. I mean, it's terrible. But with the advent of new technologies, their outlook is a lot better because we can fix the problem earlier. So, well, we're going to watch this. Hopefully it'll work.
Spina bifida, or split spine, is a common birth defect of the spine and spinal column. It occurs when the neural tube, the embryonic structure that gives rise to the brain, spinal cord, and surrounding tissues, does not close properly. When this happens, some of the vertebrae fail to form a complete arch around the spinal cord, leaving an opening in the spinal column, typically in the lower back. In mild cases, called spina bifida occulta, only a small gap is formed and there are no other abnormalities. The baby may have a small dimple or birthmark with a tuft of hair on the back, but has no symptoms and does not require treatment. When the opening is large enough, a sac containing spinal fluid may protrude out of the spine. This is known as spina bifida cystica. When the sac contains only the meninges, the membranes surrounding the spinal cord, the condition is known as meningocele. Babies with meningocele typically experience mild symptoms. Myelomeningocele is when the protruding sac contains both the meninges and the spinal cord and is the most severe form of spina bifida. Babies with myelomeningocele are prone to life-threatening infections and may suffer from lower limb paralysis as well as bladder and bowel dysfunction. Myelomeningocele also often associates with accumulation of fluid in the brain, hydrocephalus, and Chiari malformation type 2, where the brainstem and cerebellum drop below their normal position, causing problems with breathing and swallowing. The cause of spina bifida is not well understood, but is likely to involve genetic, nutritional, and environmental components. Folic acid deficiency during pregnancy is a well-established risk factor. Because the defect occurs in the early weeks of gestation, folic acid-rich foods and/or supplements must be started when planning pregnancy to effectively reduce the risk. Having had a child with spina bifida also increases the chance of having another child with the condition. Other risk factors include diabetes, obesity, some medications, and elevated body temperature, either due to a fever or use of a sauna or hot tub during the first month of pregnancy. Spina bifida is typically diagnosed during routine prenatal exams. A protein produced by the fetus called alpha-fetoprotein, AFP, can leak into the amniotic fluid and the mother's blood circulation through the neural tube's opening, and can be detected with maternal blood test or amniocentesis. However, ultrasound remains the most accurate method for spina bifida diagnosis, especially during the second trimester scan. Severe cases of spina bifida are usually treated with fetal surgery, which takes place before the 26th week of pregnancy. Prenatal surgery may help reduce disability and the risk of developing hydrocephalus. Myelomeningocele identified at birth requires surgery to close the opening within 72 hours. A shunt may be placed in the baby's brain to control hydrocephalus. Most children with severe form of spina bifida also require orthopedic care, bowel and bladder management, as well as treatment of other complications.
Okay. That is that in a nutshell. Okay, didn't want no excessive breathing when y'all saw that. So we know what causes it. Well, in a sense, we know what leads to it or the risk factors for it. So what do you teach parents or what do you teach patients if they are getting ready to have babies? Take folic acid, stay out the hot tub, that kind of good stuff. So these are modifiable. Some of them, it's just like everything else. You cannot change the risk factors if it's genetic. With most of the stuff that we're dealing with now, they really don't know why, but anyway. So when we talked about the two types, it's the occulta and the cystica, and then the two types of cystica are the meningocele and the myelomeningocele. The occulta you're not going to see except for that dimple. Why do you think there's a dimple? Because they ain't got no bone. I mean, it's just a little open spot. I read that it's, some people don't even know they have it with the exception of that dimple, or they find it when they're looking for something else. Okay? So it's not visible externally. So when you get that child out, or when that mother has that child, they won't even know anything's wrong with it. Because there's really not. It's just an opening above the spinal cord. Now, when you see the cystica, that's going to jump out at you I don't really have an analogy for that, but it's going to jump out at you. Because it's going to be a physical manifestation on the lower back of that child. And like we said, the higher it is on the back, the more severe the injury is. So that's what you're looking at. And you know the difference. One of them is just fluid filled. The other one has basically part of the spinal cord in it. That's going to be your most severe. And you're going to have to take some definite actions as a nurse when you start taking care of this child when it comes out. Now, when the child is first born, it's a newborn. I mean, it's treated the same. You just have to take a few special precautions. How many of y'all, when y'all see a blister, y'all want to pop it? Everybody raise your hand. Everybody wants to do that. Don't do that with this. That's bad on the good bad scale. Because that sac is still part of the spinal processes, I guess would be the best way to put it. So your job is to make sure that it doesn't rupture. Now, will they rupture spontaneously? Sure, just like everything else. But we want to do everything in our powers to keep it from rupturing because they're going to have that surgery. How long did the guy on there say they want to do surgery? Within 72 hours. That's a heck of a note. I was just born, and now they're doing all this other nonsense to me. So that's what the occulta, and you see the difference between the meningocele and the myelomeningocele. Like I said, it's not going to be something that you go, hey, look what I found. It's going to be there. And then they do testing prior to birth. Y'all ever heard of the AFP test or the alpha fetal protein? What that is they test the amniotic fluid for the presence of spinal fluid from the baby. If it's present, there's a likelihood that the child may have spina bifida. Now, they confirm it with ultrasound and all this other kind of good stuff, but that's the first clue. How many of y'all know people that don't want to get that test because they don't want to know? I know several people. But that, that's always the patient's choice if they want to do that or not. All right, that's just another great picture of it. A normal spine compared to the myelomeningocele, compared to the meningocele and the occulta. Yeah. Okay. So how do we diagnose it? The alpha fetal protein and the ultrasound. Now, why do we want to know? Well, we want to know what we're going to be dealing with, but with the new technology, they can do in utero surgery, which is shown to have tremendous benefits for the baby. Because the guy talked about they're at risk for hydrocephalus, right? And the Chiari malformation, which pushes that brainstem down into or it herniates is what it does. So if they can fix this, there's a good chance that herniation won't be as bad and the child won't suffer as bad of consequences from the hydrocephalus. So, how should this child be delivered if it's got a big meningocele? C-section. You don't want to be squeezing it out through the vaginal opening because you take the chance of rupturing the sac. However, after the fetal surgery, they usually can have a vaginal birth. So, that's another benefit. That's a lot less trauma on the mama. Okay. This is the fetal surgery.
My name is Robin Bowman. I'm the director of Lurie Children's Multidisciplinary Spina Bifida Center and a fetal neurosurgeon with the Chicago Institute for Fetal Health, one of the few comprehensive fetal care centers in the country. Approximately 1,500 babies are born each year in the United States with open spina bifida. In many cases, our experienced team can repair this birth defect while the baby is in the womb. This video demonstrates our minimally invasive fetoscopic repair for open spina bifida. This technique is designed to reduce the risk for mother and baby undergoing fetal surgery while preserving the option of vaginal delivery. Babies with open spina bifida who underwent back closure before birth have been shown to have long-term an improvement in their leg function, less of a need for hydrocephalus treatment, and improvement in the imaging of their brain. Open spina bifida occurs when the bones of a baby's back do not close properly. The baby's spinal cord extends through the open bones and attaches to the skin. This birth defect most often occurs in the baby's lower back region. Open spina bifida also has an impact on the developing brain. Babies with open spina bifida may develop an excess of spinal fluid known as hydrocephalus. The back part of their brain may also sink down into the neck, and this is known as hindbrain herniation. Fetal closure of the exposed spinal cord has been shown to help improve the hindbrain herniation and decrease the development of excessive brain water. The repair of an open spina bifida is done before 26 weeks gestation. Let's walk through this procedure. Once the mother is prepared for surgery and under anesthesia, we create an incision on her abdomen. A transverse or horizontal incision is made across the lower abdomen. In some cases, a midline incision is made. The abdominal muscles are then opened in the midline, the abdominal cavity is entered, and the uterus is exposed. Intraoperative ultrasound is used to precisely identify the position of the baby and the placenta, which helps us plan our entry points. While watching with the ultrasound, the initial port is inserted into the uterus. Warm, humidified carbon dioxide is then infused into the uterine cavity to expand our working field. We then insert a camera through the port and watch on the viewing screen as 2 additional 3mm ports are inserted into the uterus. After all 3 ports are inserted, the fetus is anesthetized and the back closure begins. We begin by releasing the spinal cord from the surrounding tissues. This allows the cord to relax back within the canal, and we then close the spinal cord with a few stitches. Our attention is then turned to the dura, or the tough membrane covering the brain and spinal cord which holds in the spinal fluid. The dura is freed circumferentially and closed in a watertight fashion. Lastly, the skin is undermined and closed in the midline. Occasionally, the defect is too large to allow primary skin closure. In this situation, a patch is used to close the skin opening. The fetal repair portion of the procedure is now complete. To further protect the baby for the duration of pregnancy, warm fluid and antibiotics are placed within the uterine cavity. All ports are removed and the incisions are sutured closed. The mother's abdominal wall and skin are closed. The fetus continues to develop and heal for the duration of the pregnancy. During this time, the hindbrain herniation may also correct itself, as the cerebellum will likely move back into place. Ideally, the pregnancy continues to full term, at which point the baby is delivered vaginally and cared for by our expert team of specialists. The Chicago Institute for Fetal Health and Lurie Children's Hospital is home to one of the oldest and largest multidisciplinary spina bifida centers in the world. The Spina Bifida team is comprised of a variety of surgical, medical, and rehabilitation experts who are focused on assisting each child with open spina bifida reach and maintain their highest developmental potential. The Chicago Institute for Fetal Health team will ensure you and your baby's care is individualized and thorough throughout your child's life.
Now, how cool was that? You think they were nervous first time they did it? Because you think about the size that you're working on. Whatever. I'm not sure how big they actually are. But you see how that can help with all the other issues. That hindbrain herniation. They may regain some of their function. It's going to reduce the likelihood of bad hydrocephalus, because what happens if they have hydrocephalus? What do they have to put in? A shunt. And those are always a problem. They always get clogged up and then they have to do other things with them. But by doing this, they preserve a lot of the function that baby might lose if they allowed this to just progress like it normally has. Sometimes they can't do it. Sometimes they're not in a position to do it. I mean, we cannot do that at Anderson Regional Medical Center. Never mind. We'll just leave that where it is. But like I said, the level of injury affects your level of function. If it's below the L2, where's the L2? Somewhere around in here, right? Lumbar, you know that thing in your car where you hit your button on the side of it and it blows up? That's your lumbar. Got to be simple today. But if it's below that, they're going to have flaccid partial paralysis of the lower extremities. That means they ain't going to work. And they're going to be subject to a lot of problems. How many of y'all have ever seen a spinal cord patient that's paralyzed, that has flaccid paralysis below their waist? That creates issues. It creates issues of positioning. It creates issues of urinary and fecal problems. So they have a sensory deficit. You know, these are the people that can't feel their feet and can't tell if they're burning them off when they're sitting in front of the fire. They have overflow incontinence. Their bladder doesn't know when to hold them, when to fold them. So think about an infant. Is that an issue? If they haven't had that repair yet, do we want a bunch of urine and poop getting on the spinal sac or the meningeal sac? No. So they're not going to have bowel control. They have rectal prolapse. What does that mean? Who what? Their booty hole done fell out. Ain't that what it is? It's dragging around like a kangaroo tail. Except they can't walk. No. They're too young. No. So, if they have rectal prolapse, do you think that creates an issue for cleanliness, for hygiene? Sure. Okay, if it's below the S3, which is your sacrum, you know that one that nobody really talks about until you fall on it when you're old and you break it? They're going to have no motor impairments, but they may have joint deformities. The knees and the hips. They're going to have clubfoot. Y'all remember that from peds? The valgus and varus contractures, that's the clubfoot and I forget the other one. But just know that they're going to have hip problems, hip dislocations. These are likely when you have that injury at that level. So you, as the nurse, have to do things to prevent it. A lot of it has to do with positioning. How are we going to position these kids? Because it's important. Now, when they're first born, they're a newborn. You have to do the same things. You got to do all them scores and all that other kind of weird stuff that y'all do to kids that I don't really care for. But they're just going to need a little bit of extra special care. And your job as that nurse is to know what to do, but more importantly, what not to do. Okay, they're going to have neurosurgery or neurology. They're going to have a peds, urology, orthopedics, rehab, social services. You are now the care manager. You need to be coordinating with all these folks. You need to be talking to them. Bless you. So the neurology and the neurosurgeon are going to try and repair it, and then it's going to be in the hands of your rehab folks. Who needs to be taught how to do all this? Well, you do for one thing, because you need to know how to handle them. But you want to get the parents involved early in that child's care, because they may need, well, we'll talk about that in a minute, what they're going to need. Orthopedics, they may have to have several orthopedic surgeries. But they're definitely going to have PT and OT. Because this child, if that injury is high enough, is going to be limited. They're going to be in a wheelchair. And then they're going to need social services. Do you think that these parents and these patients are going to need special things at their house? Like what? What's one thing they're going to need? A wheelchair. Ramp. Is that the one where you get them downhill and then they... No. That's the other ramp. What else are they going to need? Special beds. Special stuff for baths. Lift chairs, all that kind of good stuff. You don't think about the depths that they have to go to manage these kids. Because what do kids do? They get bigger. I mean, it's one thing to take a 3-month-old and stick them in a bathtub. It's another thing to take a 14-year-old and stick him in a bathtub. One, he ain't going to want you to see him. They weird. I am 14 years old, Mama. You don't need to see all this stuff. Son, I have seen it since the day you came out. Yeah, but you don't have to see it now. Besides, at 14, they don't want to take a bath anyway. They just want to stink. Now, these are boys. Girls are completely different. They're not. Well, some are, some aren't. I just never have figured out why about the age of 14 they start stinking. They don't quit till they're about 22. I got 2 at the house. I go broke on them things you plug into the wall. And they spend all day in the shower. Huh. Oh well. I don't want to know that either. But the initial care is maintaining a neutral environment. Do we want these kids getting hot? Do we want them getting cold? No. What are we going to put them under? We're going to put them in a tanning bed, right? Ain't that what it is? A tanning bed? An incubator or a warmer or whatever. All right? But they got a big old honking sack on their back. A back sack. Do we want it drying out? Y'all ever seen a baseball glove that sat out in the rain and then it dried out? What does it do? It breaks apart. Or like one of them balloons that your kids hide and then you try and blow it up and it just busts. Same thing. We want to keep the sack moist. How often do we change that dressing? It's right up there. It's important because if that sack ruptures, you have bigger issues. Inspect the sack. It's a sack. Okay. Do what? It's like a wound or anything else. You want to know from hour to hour, day to day, has it changed? Because they're going to be going to surgery pretty quick. And hopefully they'll get this defect fixed. But while they're in your care, it is your responsibility to maintain this sac so it's viable and not ruptured and all that other kind of good stuff. There was another word, but I couldn't think of it. We don't want it contaminated. Don't let the kid pee on it. Don't let it poop on it. Do you think that cleaning this child is going to present some challenges? Not only do you have that little bitty booty hole you try to work with, now you got to keep this big old sack clean. You've got to be careful.
I get it, though.
But think about it. Think about the challenges that nurse is going to have trying to preserve this sac. It's a lot. Assess frequently for signs of infection. How can we tell if they're a baby? We're going to measure their temp, right? We're probably doing blood work. So we want to make sure we do rectal temps every 4 hours, right? No, their booty hole done prolapsed. You can't be sticking a thermometer up in there. So when you see that new nurse come in with that rectal thermometer, get away from my baby. I don't know who you think you're using it on, but you ain't using it on this baby. They are contraindicated. Because anything that can damage that sac has to be prevented. That's why, how are we going to position them? We're going to lay them up on that thing so we can spin them around like a top, right? No. You got to have them prone. What does prone mean? On your face. Ooh, last time I heard that, that was just an ugly, get on your face. 20. Sorry, military thing came back, sorry. But why do we want their hips slightly flexed? To who? To keep pressure off the spinal cord, and what else? To prevent dislocations. Because it's bad enough they got a big old sack hanging on the back. Now the hips are dislocated too. We don't want them walking out of the hospital like this. You've got to keep joint integrity. Okay. We want to, what does abducted mean? Huh? Yeah. Yeah, because if they were adducted, they'd be like this. If they're abducted, they'd be like that. You know, like a frog. You want them in a frog position. That's basically what it looks like. And once again, no rectal temps. Because what happens if you perforate the anal canal? Well, now you got something else the surgeon's got to deal with. And really, you've done a disservice to that child and the parents. All right. So that's what they're going to look like. You've got to do that assessment of that sag. But don't be punching on it. We just want to make sure it stays. What kind of dressing are we using? Sterile, non-adherent. Because we don't want nothing sticking to it. We ain't ripping this thing off like a Band-Aid. All right? We're going to do a neuro assessment. But you have to do it carefully because you don't want to dislodge anything. Intake and output. You think it's going to be hard to feed this child? I mean, they don't want to eat as it is most of the time, and now you got them laying like this. So you want to make sure that they have a good fluid balance. You want to make sure that they've got all the nutrition that they need. Because if nothing else, they're going to be healing up from another surgery shortly. And we're going to do an abdominal assessment. Well, how are we going to do that? They're laying on their stomach. Well, I didn't mean you can't put them up on their side and look at it, but you don't want to leave them there. You've got to be careful when you move these kids. But the assessment tells you what you're going to do and how you're going to address it. Because they're, like I said, they're probably going to be incontinent. So you got to take care of them. All right. So if they're going to be in this weird position anyway. Plus, after they repair it, do we still want to put them on? Do we still want to keep them on their stomach? Yeah, because we don't want to put any pressure on the suture line. Your book says that sometimes a surgeon will allow side lying, but that's up to him or her or they or whoever. But because of this, they're going to be at risk for pressure ulcers. Now, who would think that a newborn's at risk for a pressure ulcer? I mean, we think that they're all fat, right? And they don't get pressure ulcers because they wiggle so much. Well, if you can't feel nothing below your waist, you ain't wiggling a whole lot, are you? So they are at risk. We have to do a skin assessment. Babies don't have the ability to regulate their heat well yet, do they? So we want to make sure that we're not freezing them or burning them up. They may have urinary retention. Well, how are we going to fix that? Who? How do you fix urinary retention? Jumping down up on their bladder? A cath. How are we going to cath them? In and out. Because this is really, if you start an in and out cath, that's what that child is probably going to have to do for the rest of their lives. Guess who's going to be teaching them how to do it? How many 14-year-olds do you know that want to cath themselves 3 or 4 times a day? You got to watch out for those skin irritations. We talked about that, bowel and bladder incontinence. So as soon as they come out, we want to put a diaper on them, right? You think? Yay or nay? Who says yay? Y'all are all staring at me. Who says nay? Okay, we got a bunch of nays. Why? Who? I'm sorry, I can't hear this more. It's on the spot. We don't want to put anything that's going to irritate that sac. And y'all seen them diapers, especially if they're born early, them things come up to their, looks like an old man. Y'all seen him in a general store, walks in with his pants up to here? He can walk through a 3-inch puddle without getting his pants wet. But anyway, but we want to make sure we maintain their nutrition. Either IVF or feedings per order. Because they're still recovering from a surgery, more than likely. All right. All right, that's how they repair it. Open up the skin, stuff it back in. I'm sure it's more than that, but I'm not a surgery person. All right, so after that, we want to monitor their vital signs. Duh. Don't we do that for everybody? It's a surgery patient. Pain management, opsite care, prone or sideline. No latex. Do we even use latex anymore? Yeah, we do. Surgical gloves are generally latex. So we got to be careful. No latex after that. Unless they've come out with something else that honestly ain't been in surgery in so long. I don't care. But children that have spina bifida tend to develop a latex allergy. So we want to minimize the risk of that. That's why we avoid the use of latex. I think we're allergic to about everything now. A latex allergy occurs in 80% of kids. That's a bunch, ain't it? 8 out of 10, most. Y'all can read that. Y'all know the signs and symptoms of anaphylaxis, right? What are we going to do? Epi. What else? You think some oxygen might be appropriate? Nah, we just want to watch them wheeze. Not all of them will have an anaphylactic reaction. Some of them will have localized. But that's still a latex allergy. You have to take care of it. If it's just they breaking out into whelps, give them a little Benadryl, a little famotidine. Just make sure that you're doing what you're supposed to by not contributing to that latex allergy. Look like fun to take care of? That's the best way to position that baby. It takes all the stress off that suture line. But that thing's got more tubes than a 1937 TV. You're going to have to manage that. You got to make sure they're getting their feedings. You got to make sure they're getting their antibiotics. You got to make sure that the care is done, that they're not dirty, they're not wet, that the dressing is clean and dry. The same thing with every other surgical patient, only this one has some special needs because you've got to watch positioning, you've got to watch contamination, and you've got to do those sensory and neuro checks on them to see how badly that patient is, or what kind of deficits they're going to have. They got the hydrocephalus. We talked about that. Usually if they do that in utero surgery, that reduces, but it still can be present. So now you got to teach the parents about their shunts that are going to have to be put in to drain that excess cerebrospinal fluid. They may be paralyzed. Now you got all these other issues. You've got mobility issues. By the way, that's what we're talking about here is mobility. Some of them are not going to have any deficits. Some of them are going to be terrible. Orthopedic deformities. They may have them little bitty short legs. They're going to have to be adaptive. You as the case manager or the care manager or the nurse are going to have to start putting these things in play because that child may need specialized equipment as it grows. Or he grows, she grows, they grow. You're going to have to teach them how to in and out cath themselves. You're going to have to teach the parents how to do it first, then you may have to teach the kid. We're going to do sterile caths. When we get that 14-year-old home, CIC, clean intermittent cathing. How many of y'all have patients that do that now? None? Wow. If it's bad enough, they may have to do a urinary diversion. Have y'all ever seen that? Where they have the suprapubic catheter? Little hole right below their belly button? They may need bowel training programs. And guess what? Y'all are going to hear this again when we talk about spinal cord injuries. I ain't talking about it, but somebody will. Urinary and bowel training programs need to be implemented. What kind of complications can this child have? Who? I can't hear you. Infection. What else? If you can't pee good, you may get an infection. We need to be watching that. What else? Skin breakdown. If you can't move, you can't feel. If you can't feel, your skin breaks down. What do you think? Yeah. Yeah. You have to deal with the psychosocial issues. You think about a 14-year-old that's got to cath himself in front of his buddies. I mean, he's not going to be out on the playground doing it, but y'all hang up. I got to wheel into the bathroom for a second. Yeah, he's going to have psychosocial issues. And the parents are too. You know, because once your kids turn about, when do they get potty trained? About 2, 3? If they're boys, 23 or something? When they feel like it. But now mama's got to cath me. Mama's got to put a suppository up in there. How many of y'all want your mama sticking a suppository up there? If you like that, we have a whole different class that we need to go to. But I mean, yeah, everybody's going to have problems, adjusting. And that's why you've got to get them hooked up with the support groups. Yes, there's a support group for everything. But you've got to make sure that the social worker, when you turn that patient over to them, is doing what they're supposed to do. They're getting all this stuff in the works for that patient. Sure, they'll find a lot of it on their own because they have Dr. Google. But you got to be careful about what Dr. Google says. But they will. They'll find their own support groups. But do you really want to let them do that? You want to help them do support groups or whatever, or resources that are known, that are reputable. I would hate to think that there's places like out there that would just take money or whatever, but you know the world we live in. Okay, what do you want to teach your parents? Everything. What would be some things you do have to teach them? Wound care. What else? Positioning. What else? Catheterization. Bowel maintenance. Skin maintenance. Do what? Well, the parents are going to either have to teach them how to do their own, or you're going to have to teach the patient how to do it. We want to teach the parents prevention. If you have any more children, you need to take folic acid. This will help prevent it. Help prevent, not eliminate the possibility of. Like I said, the prognosis depends on the neuro part involved. It's all about the level of injury. Now Now this came out of your book, or this is a Elsevier thing.
The term spina bifida comes from the Latin split spine, which is actually a pretty good description because spina bifida is a birth defect where the tissue on the left and the right side of the back that normally come over the spinal cord to protect it don't completely meet up to form a nice seal, leaving behind various degrees of an opening right down the middle of the lower back. Very early on in fetal development, the ectoderm, which is the outer layer of the fertilized egg, starts to develop a bit of a ridge that eventually becomes the neural tube. This neural tube goes on to become the spinal cord, the brain, as well as tissues that enclose and protect them, called the meninges. And spina bifida occurs when a portion of this neural tube fails to close properly, typically in the lower back. This constitutes a defect or absence of the vertebral arches due to a failure of mesoderm to organize over the region of the defect, and it may or may not involve the underlying meninges and neural tissue. Alright, so there are three main types of spina bifida, and the first is myelomeningocele, also called meningomyelocele. And this is the most severe of the three and happens when the spinal cord and the surrounding meninges protrude out of an opening in the bony vertebrae and are held together by a sac of skin that pouches out from the back. In really severe cases, there's no skin at all, and the nerves of the spinal cord are therefore exposed, a condition called open spina bifida. And this can cause serious damage to the exposed nerves, as well as risk an infection, resulting in symptoms like loss of sensation or paralysis in the areas of the body below the damaged site, bladder or bowel movement problems, seizures, as well as leg and foot deformities. Now, a myelomeningocele is typically associated with a condition called an Arnold-Chiari II malformation, which is where cerebellar and brainstem tissues slip down into the foramen magnum, the opening at the base of the skull. This Arnold-Chiari II malformation results in a variety of symptoms related to the cerebellum, and often results in hydrocephalus, an abnormal accumulation of cerebrospinal fluid in the brain. Alright, the second type of spina bifida is meningocele, sometimes called a meningeal cyst. In this condition, the prenatal spinal deformities result only in the meninges and not the spinal nerves, slipping into the gaps between the deformed vertebrae. This one's the least common form of spina bifida, and because the spinal cord itself isn't damaged, these individuals often don't experience the severe symptoms that are seen in myelomeningocele. Alright, the third and final type is spina bifida occulta, and this is the most common and most mild form of spina bifida. In fact, occulta is Latin for hidden, which is appropriate since many of the normal prenatal tests used to diagnose spina bifida don't catch the disorder because the deformities in the tissues of the lower back are tiny. In spina bifida occulta, the spinal cord and surrounding tissue don't protrude, nor is any of the tissue forced into spaces between the vertebrae. Since the spinal nerves are undamaged, people with this form of the disorder are often asymptomatic, and the condition is usually only found accidentally later in life. At most, people might have hair, a dimple, or birthmark on their back above the site of the lesion. Now, the exact cause of all three types of spina bifida isn't known, but there are known risk factors, like folate or vitamin B9 deficiency during fetal development. And therefore, prenatal vitamins include folic acid, which is the manufactured form of folate. The developmental deformities, though, that cause spina bifida often take place in the 4th week of pregnancy, which is 21 to 28 days. And this could be before a woman might know that she's even pregnant, and therefore she's not taking the prenatal vitamins yet. To help combat this, enriched grain products like breakfast cereals made with whole grains have folic acid added to the flour as a general preventative measure. Other risk factors for having a child with spina bifida include obesity, poorly controlled diabetes, and taking medications that interfere with folate metabolism, like certain anti-seizure medications. Diagnosis for the most severe form of spina bifida, myelomeningocele, is often done prenatally by looking for an increased level of alpha-fetoprotein, or AFP, in the mother's serum, which can happen when the skin surrounding the fetus's spine is missing and AFP leaks into the amniotic fluid and into the mother's bloodstream. AFP, though, can be elevated in other conditions as well. So in order to get a more exact diagnosis, additional blood tests for human chorionic gonadotropin, or HCG, inhibin A, and estriol, as well as an ultrasound are usually done. In more serious cases, amniocentesis, where a sample is taken directly from the amniotic sac surrounding the fetus, can be performed. For treatment, prenatal surgery is done to close a myelomeningocele, but this surgery can be dangerous to the developing fetus as well as the mother. In cases where postnatal surgery is chosen, it's often done within the first few days of an infant's life in order to minimize the risk of infection like meningitis. Even if the surgery is successful, people with this condition typically need additional interventions like urinary catheterization to help with urination and crutches or wheelchairs in case of paralysis or low muscle tone, because the damaged or underdeveloped spinal nerves can't be repaired. Alright, as a quick recap, the three types of spina bifida are spina bifida occulta, which is the most common and least severe, meningocele, which is the least common and also typically not very severe, and myelomeningocele, which is the most severe form of spina bifida. Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel.
So, that's spina bifida. Straightforward, straight out of your book. Y'all got the page numbers? Okay. Take your worksheet out. Have y'all been answering the questions as you went, or just kind of? Okay. What's the first one? You got one behind you. Yeah, I can read. I just learned how. All right, the three types of spina bifida. We got that, right? Actually, it's two types with two subtypes, but we're just going with three. It's just easier for me to remember. Which type is not visible? Okay, what's the difference between a meningocele and a myelomeningocele? Which is worse? Okay, how are they repaired? Surgery, either in vitro or within how long? Okay. What's the nurse's responsibility for the child undergoing repair of a meningocele or myelomeningocele? Assessment, keeping the sac intact, making sure we're not using latex, making sure the child doesn't have an infection, all that kind of stuff. It's the same thing. The child is a surgical patient. The only specialities in it are the positioning, the diapering, and changing that dressing every 2 to 4 hours and making sure that it don't stick to the sac. All right? What determines the amount of disability the child may have due to spina bifida? Level. Spinal level. The amount of disability is the level of injury or the level of affected spine or whatever, however you want to put it, where it is on the back. If it's high, it's more. If it's low, it's less. What are some issues that a child with spina bifida may also have? Who? Incontinence. Who? Hydrocephalus. Who? Rectal prolapse. As the child ages, name some problems they're going to need education on. Cathing. What else? Bowel evacuation. Or as we say down here in the South, pooping. Who? Bladder training. Coping. Ooh, just thought of a question. Because we always like dietary questions. What kind of diet does this kid need to be on? Do what? High fiber. They might want to be on extra protein too because of muscle atrophy. Make sense? You want me to put a bunch of diet questions on there? Like a chicken sandwich and a milkshake and I say me. All right, during your initial assessment, what may be a clue that the child has spina bifida? They got a big old sack on the back. Woo! Look what I found, Bob. Or what? A dimple. Or some hair. Okay, when the nurse begins management of the child with spina bifida, how does the nurse care for the sac? Dressing changes every 2 to 4 hours, moistened, non-adherent. Positioning. What else? Keeping them clean, keeping them dry, keeping them not too hot, not too cold, just right, just like baby bear. Okay, what's the most appropriate positioning? Prone. What is contraindicated in the child with an exposed sac? Rectal temps. What else? Diapering. And placing them on their back. Okay. How can a child with an unrepaired myelomeningocele receive tactile stimulation? Yep. Say it again. It's in the book. So really what you're trying to do is, okay, we're still trying to promote the bonding and all that other kind of good stuff, right? Because that's what mamas are supposed to do. You can put them on a pillow and stroke the upper part of their back, that kind of thing. That's how they're going to get that stimulation. Now, you may be doing range of motion with them, especially the upper extremities. When they turn into toddlers and get terrible like they always do, to help build that upper body strength, you put them on their face, like they did in the military. Get on your face. And then you put their toys just out of reach, so they have to reach for them, and it helps build that upper body strength that they're going to need. More or less. That's the new phrase, right? Tummy time? Okay. When I was growing up, it was throw them on the floor. Seat belts. You know what a car seat was? Mama's arm. I kid you not, I slept in the back window of an LTD on the way to Texas. The back window. Now this was, well, I've never slept in the back. I think I was too tall for aluminum. But I mean, this thing was a tank. If we'd have hit the bridge was going. And Mama had her arm up as I went flying out the window. And then my parents were criminals. Here, let me turn this off real quick. Not sure if I want to taste the Rocky Mountains because they got them oysters up there that I don't really care for. Discuss the post-op care for the child with a repaired myelomeningocele. Myelomeningocele. What are we going to do for them? Monitor for infection. What else? Who? Eyes and O's. Avoid latex. What else? How are we going to position them? Prone or sideline with the approval of the surgeon. We want to make sure we're looking at the suture site. Make sure we're doing all the stuff. It's a surgical patient now. Who? Pain management. Wait, that baby ain't in pain. Babies don't have pain, do they? They got feelings. Okay, what allergy are they at risk for? Latex. Never mind. What issues can a child with spina bifida deal with? Psychosocial. What else? Bowel and bladder problems. Who? Skin integrity. All that kind of good stuff. All right, that's spina bifida. Y'all take 10.